Hello, everybody. My name is Marek Trne. I'm the head of the first department of medicine, Tcells University General Hospital. It is not far from the Congress Center where the meeting should be taken just in the moment, but unfortunately, because of the situation that the whole Congress Center has been dedicated to the Ukrainian refugees, we have to run this year the EBMT as a virtual one. Nevertheless, we have a great meeting, and I'm going to focus on the lymphoma stuff. We can hear, and something probably you can hear later on. I would like just to mention that we can divide the topics into the 3 or 4 parts. And I would like just to start to mention the presidential abstract, which was given by the Miguel Angel Perales from the United States. And it's a very important retrospective study on behalf of EBMT registry and CIBMTR, which the study has been focused on the question if the patients who are pre-treated with the immune checkpoint inhibitors have a different outcome when they undergo the allogeneic stem cell transplant for relapsed refractory Hodgkin's lymphoma compared to the group which is not pre-treated, which was not pre-treated. So altogether, there were almost 1,750 patients, and out of those numbers, 350 patients have been pre-treated with the immune checkpoint inhibitors. The groups were compared, and the main message is that the pre-treatment of the immune checkpoints inhibitor didn't hamper the treatment-related mortality as well as the overall survival. And it's important to say that the relapse rate was actually reduced. The hazard ratio was reduced by 47%, and the PFS was improved as well. The hazard ratio was improved by 25% for those patients who were pre-treated with the immune checkpoint inhibitors before the allogeneic stem cell transplant. There was the second topic regarding the allogeneic stem cell transplant, which was focused on the relapsed refractory anaplastic large cell lymphoma. And it was the CIBMTR registry analysis. And altogether, 182 patients were analyzed. And the question was, what is the outcome if we transplant those patients with the allogeneic stem cell procedure? The 1 year non-relapse mortality was 18%, and the 5 years progression-free survival and overall survival probability was 41 and 56% respectively, which is quite promising for the patient who failed several lines of the therapy, including brentuximab vedotin, and some of them the autologous stem cell transplant as well. Is anything new in the autologous stem cell transplant? So I have just one abstract selected, which was focused only on the autologous stem cell transplant, and it was again the CIBMTR study, retrospective study, which analyzes the patients who were above 70 years old. So they took 2 groups of patients between 60 and 69. the group was formed by the 363 patients, and the group above 70, which was 103 patients, all relapsed refractory diffuse large B-cell lymphoma. All patients underwent salvage and were transplanted, conditioned by the hydrotherapy beam, and received the stem cell transplant. And what is important to mention that the patient above year 70 of age, they have no worse outcome in terms of the relapse progression or non-relapse mortality. Definitely the overall survival was lower, but it was not because of the transplant procedure. The main driver of the worse overall survival probability was the age. So this is the important message for those who would like to transplant, to use the high-dose treatment with autologous stem cell transplant. High-dose treatment and autologous stem cell transplant. Then there was the group of patients focused on the ZUMA7 results. So the data were presented at the last ASH in December, and they appeared in the New England Journal of Medicine. Tom van Mjachten just to summarize the data. It has been showed in this study that the patients dedicated to the CAR T-cell therapy with Axi-cell, out of 180 patients, 170 were able to receive the Axi-cell. It's a 94%. In contrary, only 36% of patients out of 179 who have been dedicated to be treated with the salvage therapy and the stem cell transplant, actually proceed to the high-dose treatment and the stem cell transplant. The event-free survival, the main endpoint, the primary endpoint, was significantly prolonged, and the median was 4 times longer, as well as the 2 years event-free survival. The important sub-analysis was made, and this was planned sub-analysis of the patient older than 65-year-old. There was the 51 patient above 65 in the Axi-cell group, and 58 patient in the standard of care group. And it's quite interesting that the event-free survival was longer with Axi-cell. 2 years event-free survival, the median was 21.5 months in the Axi-cell group, contrary to the 2.5 months in the standard of care group. So it represents 8 times prolongation of the median free survival. Regarding the toxicity, it was fine. So I think that for the elderly group of patients in this analysis, but by definition, all those patients have to be transplant eligible. So this is very important to say. But it shows that those patients could have even greater benefit contrary to the younger patient. What about the quality of life? So it was presented at a poster session by the Mahmoud El-Sawi, and it's interesting and very important that the quality of life of the patients treated with Axi-cell was improved contrary to the patients treated with the standard of care. There were then some update of the either in the oral session or in the poster session, ZUMA5 for the indolent lymphoma, ZUMA1 The interesting study, ZUMA12, it's important to discuss. So the data were presented at the ASH, and here we can see again that the patients who are PET positive after 2 cycles of the R-CHOP treated for the diffuse large B-cell lymphoma could be easily switched to the axi-cell therapy, and the outcome is quite interesting. The 12-month progression-free survival is 81%, is 75%, and the median overall survival was 24.5%. So we 25.5 months. So we have to wait for the longer results. Definitely, this strategy has to be tested in the randomized study, but it's a promising results. And I would like to end up by the 2 topics. One is the quality of the T cells. So it has been demonstrated in the poster session by the group of Israeli colleagues that if you collect the cells earlier when the patient comes because of the progression, it means not later than after the first cycle of the therapy, your collection of the cells, your cells you collected, are healthier, are in a better quality compared to the cells if they are collected later on. And there was an interesting analysis from the real world data. For the first time, I've seen those data that if the expansion of the CAR T cell, it's oral session given by the Martina Penisi from Italy, if the expansion of the CAR T cell are bigger at the beginning of the shortly after the CAR T cell infusion, then the outcome is better compared to those patients in which the expansion is somewhat hampered, contrary. Yeah, all we discuss the fascinating data with the CAR T cell therapy. The toxicity is feasible in some situation. Maybe we could go for the outpatient. But what about the financial toxicity for the healthcare system? This is very important issue, and it was discussed on the 2 posters. One compared based on the ZUMA7 data and the model from the real world as well, compared the axi-cell versus standard of care. It has been shown that the outcome definitely is better if you use the CAR T cell therapy compared to the standard of care. The quality is a bit higher if you just compare 2 strategies, but if you count the later on use of the CAR T cell and the subsequent treatment, so then the cost is comparable. It has to be said that this is valid for the US. This is not valid for the Europe, and definitely the cost effectiveness analysis are going to be made. The interesting study was made comparing the axi-cell and the liso-cell. It was presented by the Fei Liu from the United K. It has been shown or suggested, let's say, that the cost effectiveness is somewhat on the side of the liso-cell to axi-cell. But again, this is from the United States data. and this is the company-sponsored study. So we have to be aware, and definitely it's not possible to transfer those data and those results from the US to the Europe. So let me finish that the EBMT meeting is a successful one. So we have the opportunity to discuss a lot of the issues. I would like to mention the educational session as well, and some industry-sponsored symposia, which were the attendance rate was quite high, and the discussion was really important. So thank you very much, and I just refer to see the abstracts, to see the presentation, and to discuss in a virtual session, virtual way, but hopefully we will be able soon meet face to face. Thank you very much, and best regards from Prague, and see you later.